Hi, I'm so excited to be here with you today to talk to you about the diagnosis and treatment of PTSD. My name's Hannah Roggenkamp. I'm a psychiatrist at the Veterans Affairs Medical Facility in Connecticut, United States. We have a medical system here in the US that's only for veterans, so I work there. I'm also an assistant professor for the Yale Department of Psychiatry, and I direct our moral injury resident clinic. And again, I'm very excited to come to talk to you today about PTSD. And the last thing I want to say is my heart's with you in Ukraine, and the hearts of many people here are with you. And I want to say Slava Ukraini. Sorry about the pronunciation. Let's get started. First, I want to talk about disclosures. I have no financial disclosures, and the views and opinions in this presentation are mine and don't necessarily reflect and shouldn't be taken as official policy of the United States Department of Veterans Affairs or of the Yale School of Medicine. And the information in this presentation is for educational purposes only and is not intended as medical advice or consultation. So let's talk first about diagnosing PTSD with the DSM-5 and the ICD-11. I want to note that I'm going to be talking in more detail about DSM-5 here. DSM is Diagnostic and Statistical Manual. But I also wanted to talk about ICD-11 PTSD, which is a bit different. And here in the US, we use mostly DSM-5, but I know that in Europe and other places in the world, ICD-11 is more commonly used. So the way I've tried to account for this, because DSM-5 has so many more criteria to it than ICD-11, that anytime I'm going through the criteria and one of them is also in ICD-11, there's a little green star that you'll notice right next to that symptom. And it's just important to know too that every ICD-11 PTSD symptom is inside of DSM-5 PTSD. But for criterion A, the first part of diagnosing PTSD, which is an actual event, those are essentially the same between DSM-5 and ICD-11. So the kind of events we're talking about here are the idea that the person was exposed to death, threatened death, actual or threatened serious injury, or actual or threatened sexual violence in one of the following ways: direct exposure, witnessing in person, indirectly by learning that a close relative or close friend was exposed to the trauma. And if the event involved actual or threatened death, it must have been violent or accidental. And the last one is extreme, repeated or extreme indirect exposure to aversive details of the events, usually in the course of professional duties. So first responders, professionals, for example, who work with law enforcement are repeatedly exposed to details of child abuse, that kind of thing. And so this is where those of us in the healthcare field can come in. And of course, this doesn't include indirect non-professional exposure through electronic media, television, movies, or pictures. The first kind of symptom group is criterion B, so intrusions and re-experiencing. And criterion B really speaks to one of the fundamental ideas in how PTSD works. So it's this idea that a person will experience an event that is so intense, both emotionally and physically, or that is just so disturbing that the memory is unable to be processed. And it kind of just sits like a big chunk, big piece, unintegrated into our unconscious, into our memories, et cetera. So it really just sticks around in a way kind of undigested. So when that memory gets reactivated, it's not just a memory per se, it's this re-experiencing. The event is brought up into the consciousness and experienced all over again, which is why we call it re-experiencing. So this is what criterion B is about. So the traumatic event is persistently re-experienced in the following ways. You need one, recurrent, involuntary, or intrusive memories, strong memories that come up, ICD-11 criterion. Traumatic nightmares. So when we're talking about traumatic nightmares, we're talking about not nightmares that maybe the content changes and you bring in stuff from, the present day, maybe the ending changes. Those are less strong trauma nightmares. With a real PTSD trauma nightmare, it's usually snapshots, very vivid retelling of the experience. Again, that undigested idea. Next is dissociative reactions or flashbacks. This is not an ICD-11 criterion. And this can occur on a continuum from like just brief little episodes to complete loss of consciousness. I'll just give an example of that. I had a patient who was in the Army, deployed to Iraq, and he lived in Southern California, which is where I used to live and work. And so Southern California, it's the desert. It looks a lot like Iraq, unfortunately, but he was a driver in Iraq and would be driving, to work in California. And something about the environment would trigger a memory for him. He would start having re-experiencing. But one of the things he started to feel, which was really this flashback idea, is he would start to feel the body armor that he wore in Iraq sitting on his chest and on his shoulders, which of course he wasn't wearing that just driving to work to his regular job, but he began to feel that as if it were really there sitting on his body. So that's what we call this sort of dissociative reaction, the perception and how the person sees the world around them becomes different. The next one is intense or prolonged distress after exposure to traumatic reminders, and that's another ICD-11 criterion. And the last one is marked physiologic reactivity after exposure to trauma-related stimuli. So you get an emotional reaction and a physiological reaction when you get reminded. And the physiological reactions can be sweaty palms and shortness of breath, heart racing, that kind of thing. I had a patient describe it once as an adrenaline spray, and that is, I think, a good way to describe it. And that's, again, number 5 is also an ICD-11 criterion. Criterion C is really all the stuff that patients do to avoid criterion B symptoms happening, right? This is all the stuff that they do. This is persistent, effortful avoidance of distressing trauma-related stimuli after the event. We need one here. Is one, patients avoid trauma-related thoughts or feelings. And one of the ways people do this, for example, is they'll stay very busy. They'll stay distracted all the time, trying not to internally think of the event. That's also an ICD-11. And the second one is avoiding trauma-related external reminders. So people, places, conversations, activity, objects, or situations. So this is the idea of avoiding crowds. If it's a woman who's experienced sexual assault, she might not want to be alone in a room with a man because that brings up memories if a man was the person who assaulted her, that kind of thing. And one of the kind of funny things about combat PTSD, though, is with this avoidance criterion, sometimes combat veterans will actually, even though they have PTSD, seek out material and information and stimulation that is related to their combat exposure. So, for example, they'll play video games that closely resemble combat, or they watch. I have patients who kind of search up YouTube clips of either things that happened while they were deployed or things that look like the things that happened when they deployed and watch those over and over and over again. So it's a little bit, you see a little bit of a variation in this with people with combat PTSD. Next is criterion D. I call this life is not good. And what's interesting here, you'll notice no green stars. So none of these symptoms are part of ICD-11. But it's this idea of negative alterations in cognitions and mood that began or worsened after the traumatic event, and you need 2 of these. So one is inability to recall key features of the traumatic event, usually dissociative amnesia, not due to head injury, alcohol, or drugs. I found that for my patients with combat PTSD, this one is a little bit less common. I think especially with adult trauma, patients often report, I wish I could forget. Everything's crystal clear. It can't leave my mind. Number 2 is persistent, often distorted negative beliefs and expectations about oneself, other people, or the world. For example, I'm bad, the world is completely dangerous, that kind of thing. Number 3 is persistent distorted blame of self or others for causing the traumatic event or for resulting consequences. This one can also get a little bit sticky with combat PTSD because oftentimes patients report trauma symptoms related to something that they actually were involved in, they perpetrated. And there is some blame that they deserve or guilt that they have that is reasonable. So things just get tricky. Number 4 is persistent negative trauma-related emotions, so fear or horror, anger, guilt, shame. Number 5, markedly diminished interest in pre-traumatic significant activities, so things that the patient used to enjoy. Number 6 is feeling alienated from others, so detachment or estrangement. Patients will say, they maybe feel close with their children, but they do really feel separate almost from the rest of the world. They feel like they're not part of the human race, the human circle anymore. And the last one is constricted affect, so persistent inability to experience positive emotions. And patients will say, I can feel loving feelings like for my children and maybe for my parents, but it's not as strong as it has been in the past. It's very hard to muster actual kind of happy feelings, good feelings, that kind of thing. And what I think especially interesting about numbers 5, 6, and 7 here is they look a lot like depression. We know that major depressive disorder is comorbid with PTSD, but it just makes it a little bit more complicated. 5, 6, and 7 really look a lot like depression here. And even a little bit of 4 too. So just DSM-5 is complicated. The last major symptom criterion is criterion E, which is all about hyperarousal. These are trauma-related alterations in arousal in reactivity that began or worsened after the traumatic event, and there are 2 required here. So 1, irritable or aggressive behavior, and this is behavior, right? So yelling, punching things, punching people, getting into fights, that kind of thing. Number 2 is self-destructive or reckless behavior. This I honestly don't see that often. Sometimes patients, if anything, are more averse to risk and they are more worried about safety. Next is hypervigilance, which is also an ICD-11 PTSD criterion. Hypervigilance is just like you go into a room, you look at where all the exits are, you count how many people are in the room, you figure out who would be a threat. You're outside, out in the world, maybe you're looking at tops of buildings for snipers, that kind of thing. And it's hard to turn that off. Patients almost don't even feel safe at home or in a safe environment. Next is exaggerated startle response, that idea that maybe a loud noise where most people without PTSD would go, huh, but somebody with PTSD has a big reaction. That's also an ICD-11 criterion. Next, number 5 is problems with concentration. I think this one's a little vague, but it is a criterion, so here we are. And the last one is sleep disturbance. And I actually think it's weird that ICD-11 PTSD does not include sleep disturbance, because for me, disturbed sleep is one of the fundamental things that you see in patients with PTSD. All of my patients, when they come to me for the first time, all have some kind of sleep distortion. Their sleep is terrible. And I've seen a lot of patients just overall have big improvement if we can get them sleeping. So personally, I think sleep disturbance is really important. And here are the remaining criteria in the F, G, and H criterion. F is duration, right? For DSM-5 PTSD, must have lasted for more than a month, the symptoms. Criterion G is about functional significance, so significant symptom-related distress or functional impairment in the social or occupational realm. This is also an ICD-11 criterion, so good to know. And of course, the disturbance has to be because of PTSD. It can't be because of medication, substance use, or other illness. And the gold standard for diagnosing PTSD, probably going to be less relevant to you all, is a clinician-administered PTSD scale, or CAPS-5. I just bring it here. It's good to know, but also you'll maybe find a reference in some of the journal articles and scientific research that I quote later on in the study. Here's the PTSD checklist for DSM-5, the PCL-5. It assesses PTSD symptoms in the last month. With this slide, I'm always reminded to give a big shout out and a big thank you to the people who translated my slides and made this beautiful Ukrainian translation. It was an enormous amount of work, so I really owe them a huge debt of gratitude. But this is a device that we can use to screen for PTSD. Remember, we can't diagnose PTSD with it, but we can screen for it. The page on the left there has questions about the event itself to see if it is a criterion A event. It has specific criteria. And then on the right there are the 20 symptoms, and the patients can rate those. And personally, when I'm assessing PTSD, I like to bring out a page like this, or I bring out the caps, and just to have the questions there for me to look at, to remind myself. I never rely on my memory. I don't think you should have to either, if you can. Before I talk about complex PTSD, because I thought it would be important to mention it, I do want to note that if at all possible, I put the references for the information that I'm providing you, if there are any, at the bottom of the slide. You'll see it in super, super small print. Because we put the Ukrainian translation onto the slides, it filled up the slides a little bit more. So because of space reasons, I decided to take the references out. There is a whole list of references. It's over 3 slides at the end of the presentation. So if you're wondering, hey, where did you get this information from? I want to read that. Every reference I list is listed at the end as well. So I just want to let you all know that. So complex PTSD, this is something that is an ICD-11, right? It is not in DSM-5. The DSM-5 people did not want to put this in that version of the DSM. That's outside of my pay grade, but here it is. But it's this idea of ICD-11 PTSD, which remember is a lot fewer symptoms, plus disturbances of self-organization, or DSO is how we're abbreviating it here. But it's also important to note that complex PTSD, the events that can trigger it are actually different than the events that can trigger regular PTSD. So we're looking at exposure to an event or series of events that are extremely threatening or horrific in nature, usually prolonged, repeated events from which escape is impossible: torture, slavery, genocide campaigns, prolonged domestic abuse, being a prisoner of war, repeated childhood sexual and physical abuse. Those are the types of experiences that can cause complex PTSD. And there's 3 sort of kind of symptom domains here that we look at. The first one is a severe but stably negative self-concept. It's this idea that the patient has persistent beliefs about themselves as diminished, defeated, comes along with feelings of shame and guilt, just feeling really bad about yourself persistently. And next is interpersonal difficulties. So it's avoiding relationships and having difficulty maintaining relationships. It's hard to feel close to others, just generally not doing well with that. And the last one is emotion regulation difficulties. So difficulty calming down. Emotional numbing is part of this. And it can also be complicated by suicide attempts and self-injurious behavior. It's important to note, I think sometimes people get confused. We're not talking about emotional lability, so emotions going up and down. It's really, again, problems calming down. A lot of the emotions that people feel are pretty negative. You might see heightened emotional reactivity to minor stressors, violent outbursts, reckless, self-destructive behavior, that kind of thing. And for this complex PTSD per ICD-11, you need 2 symptoms from each of the 3 criteria for PTSD, and then 2 from each of the 3 domains of the disturbances of self-organization. So this is the International Trauma Questionnaire that we can use to screen for both ICD-11 PTSD and ICD-11 complex PTSD. It's 2 pages. Again, it's great for screening purposes, and it's been validated to distinguish between the two, and it is available on a website. You see it's traumameasuresglobal.com/ITQ, and it is available in Ukrainian on there, and my wonderful translators did it as well. But a great tool for you to use if you'd like. Before we move on, I just want to talk about 2 things that can affect the people around the patient with PTSD. So one is secondary traumatic stress. So those are the negative effects of close contact with trauma survivors, and you can see that in family and friends. It's described by Figley from 1983 as the natural consequent behaviors and emotions resulting from helping or wanting to help a traumatized or suffering person. And it kind of encompasses 2 domains that can look a little bit like PTSD, but there's also a burnout component. Burnout is defined as a syndrome of emotional exhaustion, depersonalization, reduced personal accomplishment that can occur in people who do people work of some kind. And if you are a family member of somebody with PTSD, you're kind of doing people work. In secondary traumatic stress, we don't usually see that re-experiencing and that reactivity as much as we do maybe in actual PTSD. And what's funny is it can actually occur suddenly without warning. All of a sudden, the patient has the symptoms. The next thing is just vicarious trauma. So this is described as the transformation in the therapist's inner experience resulting from the cumulative empathic engagement with clients' traumatic material. And we do see PTSD-like intrusions here. And this experience can just have a profound effect on the therapist's worldview, on their self-view, their sense of meaning and identity, and their professional functioning, as well as their personal relationships. And one of the risk factors here is a lack of support at work. So that can be a big problem. And with vicarious trauma, we usually see a gradual onset. It creeps in slowly over time. It can appear suddenly, but it's usually more subtle and creeps in. Okay, we'll leave the diagnosing and the criteria behind, and let's go on to talking about some medical considerations in PTSD. But before we really get into that, I just want to say a couple of things about the information and the research that we're going to be reviewing today. So it's important to note, which you probably most of you know, that PTSD is more common in women than in men. However, many of the US research trials that we rely on were done in men with PTSD, not in women. And this is just because of the participant pool that we have with the Veterans Affairs healthcare system that I work in. It's predominantly male, although female patients are coming in at record rates. And we think that there's probably a lot of reasons why it's more common in women than men, but there's also probably a role of reproductive hormones in symptom development and maintenance of PTSD that has been like completely overlooked from a treatment and research standpoint. And we really need to do a lot more work in this area. So for example, there's the effects most likely of menstrual cycles. So I have the menstrual cycle here in this figure on the right, but we see women as having an increased risk for anxiety disorder development or symptom exacerbation during that luteal phase of their menstrual cycle, so that premenstrual time. And this is an example from anxiety disorders, but it could speak to PTSD symptom worsening as well, related to the menstrual cycle. And then another study found elevated activation in the brain circuitry responsible for arousal, the hypothalamus, the amygdala, and the cingulate, that this type of elevated activity was associated with elevated estradiol, in response to emotional stimuli. So very interesting reproductive hormone things going on here that I just wanted to make you aware of and give you a heads up to have a look out for this type of research, hopefully more of it in the future. I'm bringing you this because study population matters. That matters regarding what response we see to treatments, especially with medication. So I'll give you some examples of this from two studies. One is by Davison et al. From 2001. Patients with PTSD who were given sertraline. In this sample, it was 75% women with 202 completers, and the study lasted 12 weeks. The mean sertraline dose was 150 milligrams. And what they found at the end of the study period was that sertraline was superior to placebo on the PTSD scales on the outcomes at the end point. And they actually saw a steeper improvement slope for the patients who had gotten PTSD versus placebo, especially after the first 4 weeks. So people on sertraline got better faster. And when they analyzed the data, they found a 60% responder rate for sertraline, only a 38% for placebo, which is actually kind of high, but we won't worry about that part of it. But very strong response to sertraline. It's important to note that these patients did have lower baseline PTSD severity scores, but than the study we're going to talk about next, but still. So this other study from around the same time period by Zohar et al. From 2002 was again PTSD patients given sertraline, but this time 95% male, and it was in veterans, a total of 42% participants over 10 weeks. Some of them had combat-related PTSD. Same mean sertraline dose, 150 milligrams. But in this population, sertraline was not different as far as outcomes compared to placebo and just general change. So it just didn't work the same way or with the same efficacy as it did in the majority female sample. And we analyzed the people who completed the study. There was a 41% responder rate for the sertraline, but only 33% for placebo, which was not statistically significant. So they didn't separate from each other. But regardless, a much lower responder rate than for the female majority sample. One thing that they did find that anger symptoms that are part of PTSD were lower with the sertraline group versus the placebo group, but still that's not our primary outcome. So we're really seeing differences in how men and women respond. I think that's just really important to know about. Next, we're going to get a little bit into like some this is probably the most sciencey we're going to get here, so I apologize in advance. But we're going to talk a little bit about noradrenergic and serotonergic functioning in PTSD. Talking about this research study done by Stephen Southwick et al. From 1997, actually done here at Yale at the VA in Connecticut. So they wanted to look to see how different neurotransmitters worked in PTSD. And they did that using two different drugs. One is yohimbine, which is an alpha-2 receptor antagonist that activates noradrenergic neurons by blocking the presynaptic alpha-2 adrenergic autoreceptor. Oh my gosh. We're going to see a picture of that alpha-2 adrenergic autoreceptor in a little bit. But it's used as a probe for noradrenergic activity. So it helps the norepinephrine stay in that synaptic cleft in the neuron longer. But what about serotonin? They use something called metachlorophenylpiperazine, MCPP, which interacts with the serotonin transporter and several serotonin receptor subtypes. And that is used to investigate serotonin functioning in panic and OCD, that kind of thing. So you have one thing that messes with noradrenaline, norepinephrine, and one thing that kind of messes with serotonin. So in the study, they had 26 Vietnam combat veterans with PTSD versus 14 non-combat healthy controls. Mean age was 41. 18 of the Vietnam combat veterans also met criteria for major depression. 6 met criteria for panic disorder, and 20 for alcohol dependence. So these were patients with a lot of alcohol problems. And there were 3 test days. On each day, the patients got 2 10-minute infusions. There was a day where they just got saline. there was a day where they got the MCPP in both infusions, and one day where they got yohimbine in one, saline in the other. Why they did that, you'd have to read the study, and they looked at how those infusions affected panic attack symptoms and PTSD symptoms. So here's the outcomes that we found. In the PTSD patients, 11 or 42% had a panic attack with the yohimbine, and 31% had a panic attack with the MCPP. And we kind of saw a somewhat similar response to flashbacks as a result of those two substances when looking at the results versus the patients who were healthy and did not have PTSD. They had almost no response to either drug, except for one had a panic attack with the yohimbine. And they looked at the data a little bit more, and I have it in this figure here. But they found that, again, 11 had panic attacks with the yohimbine and 8 had panic attacks with the MCPP, but only 3 had panic attacks with both. So 8 of those 11 only had a panic attack with the yohimbine. 5 of the 8 only had a panic attack with the MCPP. Again, 3 had panic attacks with both. So in the discussion, they write, from the results of the present study, it's possible to speculate that patients with increased behavioral sensitivity to yohimbine might benefit from drugs that reduce noradrenergic functioning, whereas patients with increased behavioral sensitivity to MCPP might respond preferentially to drugs with primary actions on serotonin functioning. So what they're saying here is that patients can present with probably about the same symptoms, but you have different systems driving those symptoms. You can have a noradrenergic system driving the symptoms or a serotonergic one. And I think that's really important when we're looking at medications and the results of studies and the different options that we have in order to treat PTSD. So what are my sources for my treatment recommendations? One is my own clinical experience that I have from seeing patients with these issues for about 10 years. The next is peer-reviewed published research. And again, I have all my references at the end. And the last is the Veterans Affairs Department of Defense from the US, their clinical practice guidelines, or CPG, for the management of PTSD and acute stress disorder, which were written in 2023. And I just also want to make a quick note about effect sizes. So they basically assess the magnitude or the strength of a research finding that occur in research studies. So it basically looks at how much of a difference there is between two groups and how strong that relationship is between these variables. So an effect size, which is denoted by a D of 0.2, is considered a small effect size. So there is a relationship, but it's a small one. Effect size of 0.5 is considered medium. So we would consider that maybe a 12-point reduction on something like the CAPS or the PCL-5. So again, drop by 12 points, that would be considered a medium effect size. And then 0.8 and up is considered a large effect size. And it's important to note too that the effect sizes will be shown with like negative or positive. So if you have reduced PTSD symptoms, that effect size would be negative. So just a heads up. The last thing I want to talk to you in this area of medical treatment is sleep. So traumatic event exposure is definitely related to the development of sleep problems. And I always say this to my trainees and to the patients, but if you're not sleeping, if you're a trauma patient, you're not recovering. And it's actually the case that getting your patient's sleep in order may decrease PTSD symptoms as much as any trauma-focused therapy on average. So here's that effect size of negative 0.6, so a medium effect size of a drop in PTSD symptoms. And it's important to know too that just treating the PTSD symptoms isn't going to make sleep problems go away. You might have to address them directly. And there's a clear link between obstructive sleep apnea, or OSA, and PTSD that I want to talk about. OSA is a disorder of recurrent or partial or complete upper airway collapse during sleep, leading to snoring, reduced ventilation, intermittent or cumulative hypoxemia, frequent arousals from sleep, and alterations in sleep architecture. And there's evidence that sleep fragmentation and sleep deprivation may actually promote airway collapse, and then this further increases arousals. We ask with the following questions: do you snore? Do you wake up gasping for air? Have people said that you stop breathing in your sleep? And we normally, I think classically, see this in overweight patients, but I'm going to tell you it's very, very prevalent in PTSD. One meta-analysis found that there was a 75% prevalence of sleep apnea in general in PTSD, and a prevalence of severe sleep apnea, severe OSA, in 43.6%. And it seems like they are sort of bidirectionally predictive of their development. If you have PTSD, you're more likely to develop sleep apnea. And if you have sleep apnea, you're more likely to develop PTSD. We call sleep apnea also sleep distorted breathing, but it's very common in trauma patients. And it doesn't matter, the age or the fitness. One sleep study in active duty service members in the US found that 63% of these young, fit service members had OSA, and only 11% of them had normal sleep. And we treat it with the CPAP, continuous positive airway pressure. We've seen that if a patient who has PTSD and sleep apnea uses the CPAP, they have a reduction in PTSD symptoms, which is phenomenal. Here's a study that demonstrates that. This was actually done in veterans, looking at CPAP compliance, the number of nightmares per week after CPAP therapy. So on the x-axis, you have CPAP compliance. On the Y, you have nightmares per week after CPAP, and you can see that the more compliant a patient is with a CPAP, the fewer nightmares they have. What they found is for every 10% improvement in CPAP compliance, it decreased the mean number of nightmares by 1. So really important to treat sleep apnea if it's there. But CPAP compliance can be really difficult. Okay, so it's important to work pretty aggressively with your patients on this. And now I'm going to pause, and please stick around for part 2.